Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. And we've had a lot of questions about, general health care with physicians, but also we've had a repeat request to talk about minimally invasive techniques, particularly in urology. And I said to myself, well, where am I going to find somebody? So I knew right away where I was going, because we have a second-generation urologist, because his dad was very well known in the community of South Florida, and we have Dr. David Taub, who's now going to have that wonderful reputation, who's a urologist at the Lynn Cancer Institute at Boca Regional Hospital. Welcome.
Thank you, Dr. Lippman. Thank you for having me.
Good to have you. And really, I think this next guest is sort of I would say, a premier view of what healthcare will look like, I believe, very, very shortly in the next 10 years. And that's Dr. Tami Singh, and she's with Aspire Health, which is a direct primary care practice. So, welcome.
Thank you.
And tell me what a direct primary care practice is.
So, direct primary care is a membership model. My practice particularly is family medicine. I see patients as newborn all the way up to elderly patients. And it's a membership model where patients have access to me for monthly membership as low as $29 for kids based on a tier system, all the way up to $100 for anybody over the age of 65. That gives them access to me unlimited through office visits, cell phone, text message, emails, and video conference. I also have an in-office pharmacy that I can dispense medications to my patients that actually come out cheaper than what they can get at the pharmacy. And I have self-pay prices for patients when they go for imaging as well if they don't have insurance. This model is particularly for either patients who don't have insurance or have a high deductible plan or somebody with catastrophic type of insurance. I'm also a yoga instructor, so I'm able to offer yoga to my patients as a membership benefit. I also do Reiki healing to my patients, and that's also another benefit that my patients take advantage of. I get lab work as low as $5 for a lipid panel, and I pass those savings on to my patients.
Well, you just did your whole advertisement right here, but I'm glad you did. I think it's important for people to know. As you probably both know, at Nova Southeastern University, healthcare education is a major part of what we present. We have, 9 schools with about 36 individual programs within those 9 schools. So we have the whole total holistic issue. I think that healthcare in general is moving to what I would call the holistic preventative wellness world, and we'll talk at greater length. Dr. Taub, talk to us about your particular practice and your association with Lynn Cancer Institute at Boca Regional.
So, urologists specialize in the urinary tract in men and women, and the reproductive tract in men. My niche in urology is urologic oncology. So I do a lot of urologic oncology and robotic surgery. I happen to be at the Lynn Cancer Institute. As you were mentioning, medicine these days is a team sport, and I'm able to provide my urologic oncology patients with the best care in a multidisciplinary setting. So we have radiation oncologists, we have medical oncologists that are in the same building. We see patients all at the same time together, so it's kind of one-stop shopping for the patients, and we have social work and nutritional support, and really want to support these patients in a holistic way, as you have mentioned.
The thing that we hear from the folks out there, and that's why we have these programs. I mean, I don't make up the ideas; they come up with the ideas, and one of the reasons why I wanted urologists back on the show is because there are 2 things that there are constant questions that come from the people out there. Number one is an oversimplistic thing, but it's not oversimplistic, kidney stones. All the time I hear issues relative to kidney stones. And the other thing is, obviously, minimally invasive surgical procedures. Now, When I tell you that the people out there always ask about three things. They ask about cancer, heart disease, and surgery. And surgery, with all due respect to everybody else that's out there, that's what they're thinking about. And the surgery issue, they want to know, why do they want to know about minimally invasive techniques? Because they envision surgery as a lot of cutting, a lot of bleeding, and a lot of pain. Minimally invasive techniques, in many, many, many cases, if not all, mitigate all of those anxieties. So
absolutely.
It's in your hands.
Absolutely. So the first step in minimally invasive surgery was laparoscopy. So little ports or channels in the belly, blowing the belly full of air so we can see, using a camera, using small instruments. Those instruments were very rigid and not able to be precise. The robotic, the Da Vinci robot machine, has allowed wristed movements. The instruments are no bigger than the pinky fingernail, so they're very small. So we're doing all this work with really small little manipulations. People wake up with minimal bleeding, minimal pain, back to normal activity, really within several days.
Okay, so Dr. Singh, now we're going to link you to an issue that Dr. Taub just discussed. Obviously, you really epitomize what we as a medical health education venue is, in at least 60% of what our students are involved in are in the multiple healthcare areas here at Nova Southeastern University. But we have a DO program, which was the mother program. It started back in 1978, graduated as first class in 1985. And now we have an allopathic program, an MD program. But other than that, we have all the other programs. We got pharmacy, optometry, dental, nursing, all of the, what used to be called allied health, but now is called healthcare sciences, the PAs, the PTs, OTs, audiology, speech pathology. It goes on and on and on. I can't go through the whole 29 of them. But here's a person that presents to you in your practice, whether it's a male or a female, that has a problem. But let's talk directly to the minimally invasive technique. You have a male comes in and you do tests, and all of a sudden you have a justification in your mind that you have to refer this person to a urologist based upon certain parameters, a PSA or whatever it is. Take me from there.
So at that point, I personally call urologist, either if I know one in the area or I ask my other colleagues that I do know. I will personally make that phone call and try to speak to the urologist or speak to their office manager or their nurse that is in connection with the urologist in order to set up my either self-pay patient or my patient that has insurance, because about 20% of my practice has insurance stuff. And I will discuss the case with them personally on a one-on-one basis, and that's how I'll set up their appointment with them. And as well, notify my patient, this is my next step, this is what I'd like to do, how do you feel about it? Because I also give the rights to the patient at the end of the day. They're in charge of their body. I'm just here to kind of guide them and give them advice. And if they want to take my advice, great. If they want to do another option, I'm still behind them. I'm still supporting them.
So Dr. Taub, now we have the patient that Dr. Singh referred to you. See, I just gave him a referral. Just
Thank you.
Referred to you, and lo and behold, a decision was made for you to do a minimally invasive technique. Let's take the male patient. The most common thing that I hear from our audience is prostate cancer or the alleged prostate cancer. And you're involved now in doing a minimally invasive technique. Take me a bit through it, and then how do we get the patient back to Dr. Singh?
So thankfully to Dr. Singh and other great primary care physician internists, the PSAs are being checked once every year or 2 years. The high-risk patients are being screened, and we're really diagnosing prostate cancer much earlier, at an earlier stage, a curative stage. And so we're seeing them early. We would have a nice consultation with the patient, going over the options, where we prefer clearly to make a living doing surgery, but we prefer to not do surgery if there's any other options. For older patients, maybe radiation would be an option. Newer options for targeted lesions, for index lesions, high intensity focused ultrasound is a less invasive surgery, but we would do a minimally invasive robotic prostatectomy. The patient would be in the hospital one night. The surgery is 2.5 hours. They would go home with a catheter in, which would be the biggest nuisance to the patient, and come back a week later, have the catheter out, and start back to their normal activities.
Okay, so now let me take a little step further, because this is another question always comes up, because we hear many people about sexual dysfunction relative to surgical interventions. Nobody can guarantee anything. However, a lot of it's been mitigated, because what happened was a patient shows up at Dr. Singh's office, has a consultation with Dr. Singh, and talks about things. Sometimes it's difficult to talk about it, but especially sexual dysfunction, erectile issues, things of that nature. But now you do a procedure because you found that there is some reason to do some minimally invasive surgical technique. Where do we go from there?
So the earlier the diagnosis, the better we're able to spare neurovascular bundles, or the nerves that and blood vessels that supply the erections. So early diagnosis is a key to good healing. Certain lesions, again, that are, we call it a dominant lesion, is if it's in one lobe of the prostate, we can treat that side and spare the other side with HIFU. So we're looking at ways to be less invasive and less traumatic to those tissues. But we certainly have erectile rehabilitation programs where early use of Viagra or Cialis, and then there's vacuum devices, injectable medications. There's a plethora of steps we take to make sure people are on the road to healing, and we can get good responses.
If the patient needed surgery, if his PSA levels were, jumped from 1 year to another year, if the patient had some other issues going on with, either ejaculation or pain in that area, or I did an ultrasound and found a mass in the testicle, or on palpation of, exam, I found something that was, concerning for me. Those are the things that I would send to Dr. Taub.
Right.
I'm fortunate to have a specialty group that I can actually consult with online with different specialists from urologist to dermatologist. So for dermatology, I can take pictures of certain rashes if I'm not comfortable with it and ask for their consultation. Just kind of as a side note, my patients, if they allow me to, I can do that, and it's free of charge for my patients. I pay a monthly membership to this site, and I'm able to get expertise specialist referrals.
To both of you, I say, people are fed up with the high cost of healthcare. Now, that's not because of you. It's because of the costs related to what you have to work with. For example, the outrageous pricing of prescription drugs today, all right? And why? I mean, there's a good question. I can't really answer, but I just say why. There's a tremendous responsibility that one would have. Do we have too many hospital beds? Do we have too few hospital beds? Should we have more 24-hour, now it's 23-hour visit venues in the state of Florida? I think it's going to go to 48 hours very shortly. But those are the types of things that are being discussed. People think that because of the Affordable Care Act, that all of a sudden we reformed healthcare. Healthcare has been being reformed now for almost 15 to 20 years. In healthcare, we rely upon the professionals to provide the true 100% reasons and facts to drive them to accept your skills. Don't you find that, Dr. Taub?
Absolutely. I think that Dr. Singh and myself and our colleagues, whatever the insurance the patient has, I'm agnostic to that. We're just there to provide the best care we can for that individual patient. Unfortunately, the costs have skyrocketed, and Certainly, we do our best to use generic medication when it's indicated, prevent hospital stays when they're unnecessary. But we're there to do the best we can for the patient. That's the oath we took, and that's what we want to do.
Okay. All right, so now we have a situation. Let's get back to the other question which people are always asking about. They're asking about kidney stones. It seems to be a favorite topic that's coming our way. So I want to start with you. Patient comes up, Dr. Singh, and says, "Oh, I got this terrible pain. I this, and I don't know what." What are you going to do?
I do a workup on them,
Right.
definitely. I will do either like a KUB. It depends, again, on their insurance. If they have insurance versus they don't have insurance. My option is for my patients is to try to keep their costs low, and everything should be transparent. So we're really going to sit down and say, okay, well, we need to find out. These are the things we could, try if we think it's kidney stones. You had it before, go ahead and treat you empirically for, say you have kidney stones, or we can go ahead and do studies and make sure you have kidney stones and go from there. And at that time, if you don't pass the kidney stones, refer to your urologist to take it from there.
So, Dr. Taub, there's a multiplicity of reasons why people have kidney stones. Obviously, you probably, Dr. Singh, will pick that up in your review, because a lot of it has to do with nutritional intake, hydration, et cetera, et cetera. So, Dr. Taub, it's all yours.
So we live in South Florida. Certainly, a lot of our patients are working outside. They're getting dehydrated. And, we would say in the South, we're in the stone belt. We see a lot of stones. The first thing we would do is try medical. If the CT scan or the KUB shows a small stone, we would try, again, to not be non-operative. We'd try medical expulsive therapy. We would give tamsulosin or Flomax, an alpha blocker, to relax the ureter, hydration, anti-inflammatories, strain the urine, and give it a couple weeks if the patient is able to tolerate the pain, not vomiting. Eventually, we might need to go in and either use a laser to break it up, or a shock wave from the outside to break up the stone and help pass. And then we want to find out what's the stone made out of. If it's made out of uric acid, we could dissolve it with medication, urinary alkalinization. If it's calcium, we may need some dietary modification, as you had alluded to, decreased salt in the diet. It's a common misconception that calcium causes calcium stones. Really, the way the kidneys process salt, if there's too much salt in the diet, you get calcium in the urine and you get calcium stones. So low salt diet, well hydrated. People should drink at least 2 liters of fluid a day. Low oxalate intake a lot of times. Iced tea has a lot of oxalate. Healthy diet does. Green leafy vegetables. We don't want people to stop eating their greens, but hydration, decreased iced tea, decreased salt, and then we can even get a 24-hour urine test. So what is precisely in your urine? What are you doing metabolically that's not right, your body, that we can alter and prevent it?
Well, Dr. Singh, you got to be sitting there and smiling, because Dr. Taub just sounded like a primary care physician that we're working alongside of you, which he does. He works alongside, all doctors do. Mm-hmm. Hopefully today that's what happens. Mm-hmm. So what do you have to say about that?
No, I'm really happy to hear that a lot of it is nutrition and education to the patient at the end of the day. Educating them so they don't have these recurrent kidney stones, to then decrease their cost of health care. So I agree with you, the healthcare cost is increasing, and that's why I went into this model, because unfortunately I don't believe in the system anymore. I was in practice for over 7 years in Lakeland, and the hospital was running it after I was with the multi-specialty group that they bought out. And I was seeing 30, 35 patients a day. I was getting overworked and burnt out, and my patients weren't happy anymore because they couldn't see me. They couldn't get a same-day appointment. They couldn't talk to me on the phone. So that's the whole reason why I transitioned into this practice.
I would say, to be, and I'll use you since you're sitting here, but I've heard it from colleagues of yours, medical colleagues, over the years. They're talking about burning out. And yet one colleague, a very prominent cardiologist, was sitting right where you're sitting, Dr. Taub. And he said to me, he says, it's not the hard work. It's not the physical work. It's the mental exhaustion based upon the fact that you can't apply your knowledge. your knowledge base, which you acquire after years of practice. That doesn't mean that you're not smart when you get out of school. That doesn't mean that you're not smart when you're 5 years out of school. It's just that the experiences that you go through, it's just like surgical technique. You know it. I mean, you know, nobody's going to start using a Da Vinci and expect the same resolve that you've had after multiple uses of the unit, because it becomes part of you.
To decision making. So at this stage, after several hundred of these operations and being in practice for a decade, it's who to operate on, who to not operate on, which procedure, matching the patient, how to avoid complications in the operating room, and to do what's right for the patient. So you learn how to take care of people in your medical school and your training, but you really learn a lot. And we're practicing scientists. We constantly are reviewing what did we do today that we could do better tomorrow. So we're constantly learning and keeping our eyes open, so we're perfecting our craft each and every day.
No question. Dr. Singh, I always say to our incoming students at orientation, I always tell them that you're just beginning a lifelong education, because what you will learn today, what you will learn to the point where you become a resident, and then when you become a fellow or whatever you're going to be afterwards, will be different 5 years from now, 10 years from now. Everything is constantly changing, and it's your responsibility to use your mind, your body, and your soul for the purposes of knowing what you are doing, and that is you're taking care of fellow human beings. Is that the way you live?
Yes, I definitely do. So again, in my last practice, I was spending about 10 to 15 minutes with a patient. How much can I really get to know my patient in that 10 to 15 minute time? So right now in my practice, I'm able to spend an hour to an hour and a half with the patient to really get to know them personally, physically, emotionally, on all levels possible. In the insurance, model, if a patient comes in for a well-being exam, I'm only supposed to focus on that well-being exam. If they're sick and I do a sick visit, if I code that sick visit, then they'll be charged. If I code the well visit, they won't be charged, but I can't do both in the insurance model. At least in this model, I saw a patient recently. She had warts. I did her well visit. I froze her warts. I did the well visit. I did a Reiki session on her, and we talked about her blood pressure, all in one visit. So patient doesn't waste time, doesn't have to repeat coming back to the office because I'm not billing insurance.
Okay. So let me get back to Dr. Taub for a second, because I have visited Boca Raton Regional Hospital, well, a couple of times within the last year. I'm really amazed at the new institutes that are there.
We're fortunate on Boca Raton Regional Hospital's campus to have these institutes, to have the philanthropists that have helped build these institutes so that the physicians can focus on taking care of the patients.
And you, Dr. Singh?
I'm excited that direct primary care is growing, and there's over 800 doctors doing this in the country in 48 states. Recently, they passed a bill Governor Scott signed. It's called HB 37, and it protects direct primary care model from insurance regulators. So it's allowing us to practice medicine the way we would like to.
Okay, so very quickly, because we're down to the last 4 minutes of the show, what makes you different than concierge medicine?
Concierge medicine, you have to pay an upfront retainer fee of close to $4,000 to $5,000 at some time. My concept is I don't have my patients sign a contract with me. It's on a monthly membership, as less than $100 based on a tier system. And so I believe in my model so much that I'm not trying to lock a patient in. At any time within 30 days before the next billing cycle, they could cancel. Concierge medicine, they also bill insurance as well as take that retainer fee. I don't bill any insurance. Patients can have insurance. We can run it for their labs, their medications, but other than that, or their imaging. But other than that, I don't do any billing.
I think that what you're telling me, and this is my interpretation, is that you're not locking in a patient based upon their ability to come to you to have a bill paid, but you're locking in a patient based upon your professional and intellectual services.
Yes, I'm locking in them that month, and they have unlimited access to
Well,
me.
I'm not talking about the months. They're locking into you because they want your
Yes.
professional and intellectual services.
Yes, yes,
correct?
they're making that choice to
Right.
stay with me.
That's what it is.
Yes.
Okay, Dr. Taub, again, this is down to the last 2 minutes of the show, but we spoke about kidney stones, and we spoke about minimally invasive surgical techniques. But again, I give great credit to you and your dad and the many years that he served in our community. So how do we reach you at the Institute?
Our phone number is 561-955-5790. We're also online, Lynn Cancer Institute.
Do you have offices at the hospital, or is there an MOB, or you have offices external?
There's a beautiful multi-specialty building across the street from the hospital.
So that's where you're located?
Yes.
Okay, and Dr. Singh, how do we get in touch with you?
Our office number is 954-998-4468, or you can visit the website at www.aspirehealthcenter.com.
Right, and where are you located?
Right behind Plantation General. I'm in a plastic surgery building that I'm renting their suite currently.
Right, okay, well, good. Well, thank you both very much for being here today. I know you are in two different areas, but yet you are both physicians. And I think up here and in here, you're not much different. How about that? So we thank you very much for your professional skills, but more importantly, I've said this to a number of physicians that have been sitting in these seats. I want to thank you for your advocacy for prevention, and your advocacy for wellness. So I want to thank you both for being here today.
Thank you.
Folks, if you have any questions, you have any comments, there's an email address right here, and I guess you can say a telephone number if you like. Once again, thank you for showing up and allowing us into your homes. This program is called Dateline Health. We come to you from Nova Southeastern University. My name is Fred Lippman. Until next time, see you.